Welcome everyone to our Canadian Diabetes Association National Fall Webinar Series. My name is Farah Ismail and I'm a Program Manager for the Canadian Diabetes Association, and I will be your host for today. We are delighted that you are able to join us for the webinar to learn all about making diabetes complications not so complicated. Now, to start off, I would like to draw your attention to the survey. It's located at the top right-hand section of your screen. In order to better serve your needs, we kindly ask that you provide us with your input by completing the short survey towards the end of the presentation. We thank you in advance for your input. Now, throughout the presentation, you will have the opportunity to ask questions in the Q&A box located in the bottom right-hand section of your screen. And we ask that you use this box for any questions you have along the way, and our presenter will be happy to answer them either at the end of the presentation, or our team here at CDA will be happy to respond to them and follow up with you thereafter. As well, we will be displaying a few polling questions throughout the presentation. We would love for your participation in these questions. It just gives us an idea to gauge who our audience members are and their level of knowledge with regards to diabetes. Please note that your answers will be completely anonymous. Also note that you're able to customize your screens. You can expand and collapse them by simply dragging the bottom right-hand corner of each of the webinar pods. The presentation itself is going to last about 40 to 45 minutes long, and then we will have a few questions at the end of the presentation. Just want to let you know that the presentation will be recorded and we will be posting it on our Canadian Diabetes Association website so that you guys can view it at a later date. So now I would like to welcome our speaker, Dr. Jeremy Gilbert, and thank him for joining us today. But before I turn it over to Dr. Gilbert, I'd like to give you a bit of a brief introduction. Dr. Gilbert is a staff physician in the divisions of endocrinology and internal medicine at the Sunnybrook Health Sciences Centre and an assistant professor at the University of Toronto. He is a member of the Banting and Best Diabetes Care and Education Committee and Toronto Diabetes Association, as well as a co-author in one of the chapters in the 2013 CDA guidelines. Dr. Gilbert shows great enthusiasm for teaching. He completed a master's teaching program at the University of Toronto. He's also won numerous awards, most recently including the 2015 Peters Boyd Academy Student in Teaching Award for clerkship teaching at the University of Toronto. For more information on Dr. Gilbert, please read the speaker bio section located on the left of your screen. So without further ado, I present to you Dr. Gilbert.
Thank you, Farah, very much for that warm introduction, and welcome everybody to the seminar on diabetes complications. Thank you all for coming. The objectives for today's seminar is to outline the various complications of diabetes and to review recommendations by the CDA guidelines for managing various complications of diabetes. By then, we hope that you will appreciate some of the vascular protective strategies in patients with diabetes. To begin, we will start with a polling question, and the question reads, all of the following are examples of microvascular complications of diabetes except retinopathy, nephropathy, myocardial infarction, or neuropathy. So we'll give you a few moments to enter in your response. Excellent. So all of the following are examples of microvascular complications of diabetes except myocardial infarction or heart attack. That is, in fact, a macrovascular complication. And we are going to be discussing the micro and macrovascular complications of diabetes on the next few slides. So there are multiple complications of diabetes. They include microvascular complications such as retinopathy, which affects the eyes, nephropathy, which affects the kidneys, and neuropathy, which affects nerves. They include macrovascular complications, which include coronary artery disease, like a myocardial infarction or heart attack, cardiovascular disease, which may include stroke, and peripheral vascular disease, which may include amputation. There are multiple complications, as I just mentioned, and this is a outline using the body as an image of all the different areas that can be affected in the body by diabetes. You can see that there is a 2- to 4-fold increase in cardiovascular mortality and stroke in individuals with diabetes, and 8 out of 10 patients will die from a cardiovascular event with diabetes, making this condition a disease of significant potential morbidity and mortality. Diabetes is the leading cause of blindness in working-age adults in Canada, as well as the leading cause of end-stage renal disease or dialysis, and is the leading cause of non-traumatic lower extremity amputation. As mentioned, this condition certainly leads to significant morbidity and mortality with significant costs to the healthcare system. We're now going to spend some time going through some of these complications in more detail. With respect to kidney disease, we divide all kidney disease up into 5 stages, stages 1 through 5, as you can see here. This stage of kidney disease can be expressed by the renal function of the individual, which is known as GFR, or glomerular filtration rate. Stage 1, or relatively normal kidneys, is a GFR over 90. Kidney damage with mild decrease in GFR would be 60 to 89. Moderate kidney disease would be 30 to 59. Severe, 15 to 29. And with end-stage renal disease at stage 5, that would be a GFR less than 15 and often requiring dialysis. Another way of expressing chronic disease in diabetes, in addition to the GFR, which you can see on the lower part with the GFR less than 60, is the albumin to creatinine ratio. And that reflects how much protein is leaking from the kidneys into the urine. It is expressed as a ratio because we have to understand that there's going to be a certain amount of protein released, and that has to be corrected for the size of the individual and other factors, which is expressed with the creatinine. Therefore, we use the albumin to creatinine ratio in men and women to express kidney disease in diabetes, also known as nephropathy. In summary, there are 2 ways of expressing chronic kidney disease in diabetes, either by albumin to creatinine ratio or GFR. With respect to chronic kidney disease, the CDA guidelines in 2013 generated a checklist, which I'm going to review. First is that individuals should be screened regularly with random urine albumin to creatinine ratio and serum creatinine, which the creatinine can be converted and measured and calculated as a glomerular filtration rate. The diagnosis of chronic kidney disease is defined as an albumin to creatinine ratio over 2 or a GFR less than 60. One can delay the onset or progression with proper glycemic or blood sugar and blood pressure control. And in addition to those 2 aspects of controlling chronic kidney disease, individuals should be on the medication of an ACE inhibitor or angiotensin receptor blocker. Finally, it is important to prevent further complications with proper sick day management, counseling, and referral to a kidney specialist when deemed necessary. We express the stages of diabetic nephropathy as it relates to protein in the urine in the slide seen here. You can see here that the albumin to creatinine ratio at the bottom is 2, and then 20, and then 66.7, which under 2 is normal. Between 2 and 20 would be microalbuminuria, and if it is over 20, that would be considered overt nephropathy. The urine dipstick will not necessarily show microalbuminuria, and therefore would still be considered negative. But if there's overt nephropathy, the urine dipstick will be positive. Another way of expressing how much protein is in the urine is through a 24-hour urine collection, and that is sometimes ordered by physicians. Again, under 30 milligrams per day of albumin would be considered normal. Between 30 and 300 would be microalbuminuria, and over 300 would be overt nephropathy. Just to highlight, we call microalbuminuria the most useful measurement as the albumin to creatinine ratio greater or equal than 2. Often when people have their protein measured in the urine as the microalbumin to creatinine ratio, there may be a positive ratio or an elevated number, but not necessarily due to diabetes kidney disease. There are other things that can cause transient or brief periods of time of albuminuria or protein in the urine. These include major exercise done recently before the collection of the urine, a urinary tract infection, a fever, if there's heart failure that is not well controlled, in females who are menstruating at the time of the collection, or if there is an acute, severe, elevated blood sugar or blood pressure. The ways to reduce the progression of diabetic nephropathy is through obtaining the best possible sugar control, the best possible blood pressure control, and the use of an ACE inhibitor or angiotensin receptor blocker medication. As mentioned before, one of the main ways of preventing progression of chronic kidney disease is proper sick day management. This is from the 2015 Canadian Diabetes Association guidelines, and it has a list of different medications that individuals should be aware about and stop if they are in the course of an illness, which we would call sick day management. These include sulfonylureas, ACE inhibitors, diuretics, metformin, angiotensin receptor blockers, non-steroidal anti-inflammatories, and the new class of diabetes medications, SGLT2 inhibitors. In the CDA guidelines, there is this pamphlet about advice for the healthcare professionals, but as well, there is a tear-off sheet for patients about what an individual should do if they are on these medications and feel sick. So this is a very useful resource within the CDA guidelines. And when we call an individual sick where all of this applies, this is generally in individuals who are not getting enough to drink or unable to drink and starting on their way to get dehydrated. We will now turn our attention from kidney disease to eye disease, which we call retinopathy. And retinopathy screening, where one goes to an eye specialist to have their eyes examined, reduces the risk of blindness. Retinopathy is not seen very much in children before the age of puberty. So for individuals with type 1 diabetes, it is recommended that they are screened for retinopathy yearly, beginning 5 years after the onset in individuals who are over the age of 15 years. For type 2 diabetes, screening is also useful. Retinopathy may be present in 21 to 39% of patients with type 2 diabetes at diagnosis. It is recommended that screening for retinopathy in individuals with type 2 diabetes occur every 1 to 2 years, starting right at the diagnosis of diabetes. The CDA guidelines do have a checklist for retinopathy, similar to the one for nephropathy. These include screening for retinopathy on a regular basis, delay the onset and progression by obtaining proper blood sugar and blood pressure control. There is also some evidence of use of a medication called a fibrate. Fibrates are generally cholesterol medications, and fibrates have been shown to also be of some benefit in delaying the onset and progression of retinopathy in individuals with diabetes. If an individual should have retinopathy, depending upon the type of retinopathy, they may be encouraged to have treatment with laser photocoagulation or injection of medications into the eye or surgery on the eye. There are several risk factors for progression of eye disease in diabetes. These include having a longer duration of diabetes, elevated HbA1c or high blood sugars, hypertension, which is high blood pressure, dyslipidemia, which is high cholesterol, low hemoglobin level, pregnancy with type 1 diabetes, proteinuria or protein in the urine, and having severe retinopathy itself often will lead to further progression. I had mentioned earlier that fibrates can be helpful in delaying the onset of progression of diabetes. This was expressed in the field study shown here, which showed that compared to placebo, which is in the untreated group, there was a 30% reduction in retinopathy requiring laser treatment in those who had the fenofibrate compared to those people who did not. And this was a significant result that was published approximately 10 years ago. We will now turn our attention to neuropathy. We've so far discussed kidney disease and eye disease, and now we will focus our attention on neuropathy or nerve disease. In people with type 2 diabetes, screening for peripheral neuropathy or nerve disease in the periphery, meaning in the extremities, like at the tips of the fingers or toes, should begin at diagnosis of diabetes and occur annually thereafter, once a year thereafter. In people with type 1 diabetes, screening once a year should begin after 5 years of diabetes, keeping in mind that they should be after the age of puberty. Let's now turn to a poll question. The question reads, which of the following are part of a proper foot exam? Checking pulses, checking sensation of feet, or checking for ulcers or calluses, or all of the above? We'll now give 10 seconds to allow people to enter their response. The correct answer to this question is all of the above. These are all very important parts of the proper foot exam, and as a further resource, one can look in the CDA guidelines for what are the major components of a proper detailed foot exam. Nerve disease in diabetes is common. 40 to 50% of people with diabetes will have detectable neuropathy or nerve disease within 10 years. These can include sensoromotor neuropathy, which affects the ability to sense things in the extremities, and it can affect the muscles in the extremities as well. Neuropathy or nerve disease poses a higher risk for foot ulceration and lower extremity amputation. It can be painful. It can really affect a person's life, causing significant morbidity, and often requires abundant uses, large uses of healthcare resources. There are several risk factors for neuropathy. These include high blood sugar, high triglycerides, which is a type of cholesterol, high body mass index, which is a way of expressing the obesity of an individual. Smoking is a risk factor, and hypertension or high blood pressure. This is an illustration of one way of screening for neuropathy. This involves what we call monofilament testing, and the healthcare professional will place the monofilament on the individual's foot and assess whether the person can feel it or not. And depending upon how many times an individual can or cannot feel it, they obtain a score which is an expression of neuropathy. An individual should see a neurologist if non-diabetic neuropathy is suspected. And that may be suspected in individuals who don't fulfill the usual risk factors for diabetic neuropathy. So with neuropathy, it is recommended that screening occur 5 years after the diagnosis for type 1 diabetes and at diagnosis for type 2 diabetes. The method to screen includes monofilament testing, as we showed before, or testing for vibration on the big toe with a tuning fork. The treatment includes obtaining the best glycemic control or blood sugar control as possible. And then for the symptoms themselves, there are a variety of classes of medications that can be used, including antidepressants, anticonvulsants, which are used to treat seizures, opioids, like morphine, or topical agents. And these are, there are advantages and disadvantages to each one of these routes, and this should be discussed with a healthcare professional. For foot care, it is important that both the individual who has diabetes and the healthcare professional be engaged and assess and treat for any foot abnormalities or neuropathy. Screening should occur at least once a year and more often in high-risk individuals. Evaluation includes looking for structural problems, the neuropathy that we mentioned before, assessing for peripheral vascular disease by looking at the pulses and skin, looking for any ulcerations, or for signs of infection. It is important that healthcare professionals provide proper foot care education, that it is advised for people to wear proper footwear, and if there is abnormalities, to have early referral to a professional trained in proper foot care. It is imperative that anybody who has foot issues with diabetes stop smoking, as smoking is a major risk factor for ongoing progression of foot disease and possible amputation. If an ulcer is found, then it would be important to refer to a multidisciplinary team who can properly assess and manage the foot ulcer. Let's now turn to diabetes and heart disease. As we mentioned before, heart disease would be an example of a macrovascular disease, and until now we had talked about kidney disease, eye disease, and nerve disease, which were microvascular complications. Individuals are at high risk for cardiovascular disease include men over the age of 45 and women over the age of 50, or men less than 45 and women over 50 with one of the following: macrovascular disease or microvascular disease, which we defined earlier, multiple additional risk factors, especially a family history in a first-degree relative like a mother, father, sibling, or child. If there's an extremely high value for a particular risk factor, for example, cholesterol, like LDL cholesterol, if that number is over 5, that would be a very high number and give a higher risk for cardiovascular disease. Or if people have diabetes for more than 15 years of age and are if they have a duration of diabetes over 15 years and their age is over 30 at the same time. We will now turn to this polling question. What percentage of people with diabetes and established coronary artery disease have no chest pain or symptoms of angina? Angina is a way of expressing underlying coronary artery disease. So we'll give 10 seconds. Great. So the answer here is 20 to 50%. In fact, this is a very common occurrence, and people may have diabetes with heart disease and not even know that they have underlying heart disease because they don't have symptoms. This may be detected on a routine testing for another reason, and they found out that they have underlying heart disease. So it is important to be aware that not every individual with diabetes will present with the classic chest pain and shortness of breath often seen in individuals with heart disease. The CDA guidelines do have screening recommendations for coronary artery disease. These include screening with baseline resting ECG in certain patients, stress testing for patients with symptoms or other reasons, and to refer patients to a cardiologist, a heart specialist, if they are able to obtain inducible ischemia. Ischemia is lack of oxygen to the heart muscle, really underlying coronary artery disease. So the first question is, who should be screened with an ECG? These include individuals over the age of 40, if a person has diabetes for more than 15 years and is over the age of 30, if they have micro or macrovascular complications that we mentioned before, or other cardiac risk factors such as high blood pressure, high cholesterol, smoking, or family history of coronary artery disease in a first-degree relative. So these individuals should have an ECG, an electrocardiogram at rest, and this should be repeated every 2 years as part of a screening process. The individuals who should go on from a resting ECG to more stress testing or functional imaging, like a nuclear cardiac stress test, should be individuals who have typical or atypical symptoms of heart disease, such as chest pain, shortness of breath. If they have other diseases that imply a higher risk for coronary disease, such as peripheral artery disease, carotid bruits. The carotid are arteries in the neck, and bruits are a sound that one can hear when you put a stethoscope over that area. TIA, which is a mini stroke, or stroke itself. Also, further testing should be done if on the resting ECG there are abnormalities. The example given here is Q waves, which implies that there may have been a myocardial infarction or a heart attack previously. These individuals should have an exercise ECG or stress testing. If they cannot exercise, or the resting ECG abnormality is there such that you cannot interpret an exercise ECG, then further testing, either with a stress echo or stress nuclear imaging induced by medications, can be considered. Obtaining good blood sugar control is something that I've mentioned throughout this presentation. Just to highlight that every 1% reduction in A1C can reduce complications of diabetes. Even if people have very high sugars and high hemoglobin A1Cs, it is encouraging to see that even a 1% drop in A1C, even though the A1C is not perfect, can significantly reduce complications of diabetes. On this slide, you see the opposite is true. For every 1% absolute increase in hemoglobin A1C, there is an 18% increased risk for heart disease, coronary disease, or cardiovascular disease. Or cardiovascular disease. So that would include underlying coronary disease or stroke. There's also a 28% increased risk for peripheral vascular disease. So this highlights the importance of trying to obtain the optimal hemoglobin A1C, not to have it raised and to try and have it as low as possible, but of course that should be done in a safe way, not to have hypoglycemia either. We will now turn our attention to blood pressure. This question is asked, what is the target blood pressure for most patients with diabetes in Canada? 140/90, 120/80, 135/85, or 130/80, and all of these are less than those values. Let's pause for 10 seconds. Great. So there is some variability to this answer, and it depends upon each individual, but generally the target for most patients with diabetes in Canada is less than 130/80. So let's spend a few moments discussing diabetes and hypertension. As mentioned, the general aim is for a target blood pressure of less than 130/80 to reduce both micro and macrovascular complications of diabetes. Most people with diabetes will require multiple blood pressure lowering medications to get to target. So often patients are concerned that they're on so many medications, but it is important to recognize that in order to obtain that target less than 130/80, it is often required to be on more than one blood pressure lowering medication. In the UK PDS trial, which was one of the most famous trials in type 2 diabetes, there was an assessment of looking at tight control, which was an average blood pressure of 144/82, versus less tight control with a blood pressure of 154/87. And in the tight blood pressure control group, there was a 24% reduction of events or bad outcomes from the diabetes. This highlights the importance and value of trying to obtain proper blood pressure control. The benefits of blood pressure lowering in diabetes was assessed in a meta-analysis, which is a type of study where they look at many trials together, in this case 27 randomized trials together, and they put all of that information together. And the summary showed that intense blood pressure reduction by 6 millimeters of mercury on the top number and 4.6 millimeters of mercury on the bottom number caused 36% less stroke, 27% less mortality or death, and 25% less major cardiovascular events, really showing and demonstrating the true value of obtaining better blood pressure control. With respect to ACE inhibitors or angiotensin receptor blockers, which are types of medications, the CDA guidelines say, regardless of the baseline blood pressure, that these medications would be useful in individuals over the age of 55 or those with micro or macrovascular disease. They should be at the proper doses, and the reason for this is not for blood pressure reduction per se, but these medications are useful in vascular protection. That is, to prevent heart attack and stroke. There is a caution in red among women with childbearing potential that these medications should only be used in the presence of proper preconception, counseling, and reliable contraception. and that they should be stopped either prior to conception or immediately upon detection of pregnancy, and this should be discussed with your healthcare professional. Turning from blood pressure to cholesterol, the CDA guidelines do have a checklist for high cholesterol. These include checking the lipid profile at diagnosis, and then yearly or every 3 to 6 months while on treatment. The main recommendation of medication to be used for high cholesterol in diabetes is statins, and the second-line agent should be used only if the LDL is not at target despite that statin. Fibrates, which we had mentioned earlier in our retinopathy section, should be used when the triglycerides are over 10 to help reduce the risk of pancreatitis. The CDA guidelines have recommendations on who should receive statins, and again, this is regardless of the baseline LDL cholesterol. So even if the LDL cholesterol is good, these individuals with diabetes should receive statins because they have been shown to reduce cardiovascular events. Statins should be used in individuals with diabetes over the age of 40, those who have micro or macrovascular disease, those with diabetes more than 15 years and age over 30, or if they should be on statins for other reasons, such as based upon the 2012 Canadian Cardiovascular Society lipid guidelines. Once again, in the red, there is a caution amongst women with childbearing potentials that statins should only be used in the presence of proper preconception counseling and reliable contraception, and that statins should be stopped prior to conception. Once again, individuals where this is important to them should discuss this with their healthcare professional. Many people are concerned about the side effects of statins. Just to spend some moments reviewing that, these include myalgias or muscle pains, myositis, which is defined as muscle pains, and also an elevated CK, which is a blood test that is greater than 10 times the normal reference range in the blood test. This is pretty rare. It only occurs in 0.2% of individuals. Rhabdomyolysis, which is more severe breakdown of muscle products resulting in significant consequences like kidney damage. That's very rare, less than 0.1% of the time. Individuals can get a rise in their liver enzymes, which is generally reversible. That occurs about 5% of the times. And one can also see an elevation in blood sugar. Just to put that in perspective, there is a study that was released in 2010 that looked at the statin use with patients in diabetes, and it showed that treating 255 patients with statins for 4 years led to 1 extra case of diabetes, and these are in individuals who did not have diabetes beforehand, but 5.4 cardiovascular events were prevented as a result. The way I would interpret this data is that although statins do have certain negative side effects, they also have been shown in multiple studies to be of great benefit, especially in people with diabetes. So I would encourage individuals to discuss it with their healthcare professional whether a statin is an appropriate medication for them or not, based upon the advantages and disadvantages of these medications. What about aspirin? So we all agree that if an individual has had a stroke or mini stroke or underlying heart disease, that they should be on aspirin. But what if an individual has diabetes but has not yet had that? This has been studied. This is another study that I show here, the reference, about the question for aspirin as primary prevention in preventing cardiovascular disease. You can see here that as per the CDA guidelines, aspirin is not routinely recommended for primary prevention for cardiovascular disease among patients with diabetes. And that's because the data does not, the literature, the studies, does not have enough information to say that it is of definite benefit in people with diabetes. And of course, aspirin has potential side effects like bleeding, So therefore, on balance, it's not routinely recommended for individuals with diabetes as part of primary prevention. We call secondary prevention in individuals who have already had an event, a cardiovascular event, and in those individuals, it would be recommended aspirin to be used. To summarize some of the vascular risk factors we've talked about, when I am assessing individuals for potential risk for cardiovascular events, there are aspects of these risk factors that are within my control and some that are not. So I cannot change the age of the individual. So that's not within my control. And in most cases, you cannot change the gender of the individual. And for family history, we cannot change that either. However, the vascular risk factors that we can modify or change include smoking, diabetes control, blood pressure control, and cholesterol. So all of these are very important aspects of trying to reduce cardiovascular events and should be important aspects of discussing and the assessment by the healthcare professional with the individual patient to work on these aspects, including stopping smoking, getting proper blood sugar control, proper blood pressure control, and proper cholesterol control. The CDA guidelines have created a nice mnemonic that is useful to remember for how to go about obtaining proper vascular protection. And these are the ABCDEs of diabetes management. A stands for A1C, or proper blood sugar control with the hemoglobin A1C under 7%. B stands for blood pressure, which means obtaining the proper blood pressure control less than 130/80, as we discussed. Cholesterol with the LDL under 2. If they meet the criteria to treat. Certain drugs that have been shown to be useful to protect the heart, such as the ACE inhibitors or angiotensin receptor blockers we discussed, statins, which you mentioned, and aspirin if indicated. Proper exercise, including regular physical activity, healthy diet, and achieving and maintaining a proper body weight. And finally, smoking cessation. There is more information on all of these different components, especially the exercise and diet, which I have not spent much time discussing during this presentation, that is available on the resources that I will be showing you shortly. Here is a list of resources that are available to you regarding this subject we've discussed today, focusing on complications of diabetes. And you should feel free to access these resources for further information. To summarize, there are multiple microvascular and macrovascular complications of diabetes that exist. In addition to obtaining proper blood sugar control, as expressed by hemoglobin A1C, it is important to also address lipids, which is the cholesterol or LDL cholesterol, amongst other cholesterol components, and blood pressure, as these are all very important vascular protective strategies. Also, be aware of key medication groups for patients with diabetes that have been shown to be of great benefit, such as ACE inhibitors, angiotensin receptor blockers, statins, and aspirin in the right patient population. So I thank you for your attention, and will now turn the presentation back over to Farah.
Thank you so much, Dr. Gilbert. That was an amazing presentation, and you shared with us some really great insight into the complications of diabetes and things that we need to look out for, and how to, I guess, manage our complications as well. So now we're going to go on to a few questions that we have. I just wanted to let everyone participating in the webinar today to note that for the questions that we are unable to answer, please feel free to send us an email at webinars@diabetes.ca, and our team here will get back to you as soon as possible with the responses. So with that being said, I'll ask our first question. So one of the questions are, how can I monitor the development and progression of my diabetic complications?
So I think monitoring for diabetes complications is multifaceted, meaning that it's the responsibility of the individual with diabetes along with the healthcare professional. So I think that taking ownership to ensure that you get your eyes checked properly, to make sure that you do the blood work and the urine work that the physician has ordered, to make sure that you examine your feet as you've been shown by the healthcare professional, and to kind of work on those protective strategies that we've discussed today. So taking the medications as prescribed, proper blood sugar, proper blood pressure, proper cholesterol is the way to overall try and modify and reduce the risk of complications.
Great. Thank you for that response. Our next question states, if my blood sugar spikes more than 5 times a month, will this put me at a greater risk for complications?
So if the blood sugar is rising above the targets 5 times per month, it may or may not be putting at a high risk for complications. The more predictive parameter or value to look for is the hemoglobin A1C, which represents the average blood sugar over a 3-month period prior. So if there is a lot of spikes of blood sugar, this will lead to a higher hemoglobin A1C, which would lead to higher complications of diabetes. However, if the spikes are not too high and only brief, this may not affect the hemoglobin A1C that much, and therefore may not lead to more complications of diabetes necessarily.
Great. Thank you for that response. Our next question asks, are you aware of any support groups for amputees?
So I think that there are support groups for amputees. The individuals who often are involved in amputations from a physician perspective include orthopedic surgeons and vascular surgeons, and they often have resources available to them to help with that support. As well, there's opportunities for prosthetics in certain individuals and a whole structural organization around that of use of prosthetics and support with that as well. So I think we're fortunate here to have those resources available to us.
Great. And we'll take one more last question. One of our participants has asked, if I have a patient who complains of tingling and numbness in their hands and feet, what type of supports are offered, or how should I recommend them these supports?
So I think that the numbness in the hands and feet may be related to neuropathy. It would be important to have this assessed by a healthcare professional to determine whether this is in fact neuropathy or not, and if the neuropathy is or is not related to diabetes itself. We talked earlier in the seminar about ways of trying to reduce neuropathy, such as obtaining proper blood sugar control, so that would be highly encouraged. And there are medications that can be used to improve the symptoms of neuropathy, and this should be discussed with the healthcare professional to review the advantages or disadvantages of these medications.
Great. Thank you so much for that. And that concludes our webinar for today. I'd like to sincerely thank Dr. Gilbert for speaking on behalf of the Canadian Diabetes Association. It has been an absolutely great learning experience, I know for myself, and I'm sure for everyone that's participated in the webinar today. Just a reminder to everyone, our webinars will be available online on our CDA website in the next coming weeks. I do want to take the time, to thank everyone who's participated today, as well as our wonderful volunteers, who have helped coordinate the session. We'd also like to thank our proud supporters, Bayer and Merck, who helped make this presentation possible. And for those of you who have enjoyed our webinar series, this concludes our series, our fall series, but we will have a winter series coming up. It'll run from mid-November to mid-December. So for more information on speakers, topics, and timelines, please visit our website at diabetes.ca/webinars. And for any additional supports or questions or concerns anyone might have with regards to diabetes, please call us at 1-800-BANTING or visit our website at diabetes.ca. Also, please note we have quite a few different programs and services we offer at the organization. So please come to our website and visit our charter, the Diabetes Charter, visit an expo that's somewhere in a community near you, or feel free to participate in our virtual health coaching program. It's a free program offered by CDA to help individuals on a personal level reach goals so that they can better manage their diabetes. So once again, thank you everyone for participating, and have a wonderful day.